Good morning, Chairman.
Good morning, and I would like to welcome everyone who is present in the chamber and those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would also add, for those of us that are in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep those succinct and concise. As the meeting is being streamed in the usual way, I would like to remind you all that your comments will remain accessible online. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies from Councillor Thompson, Councillor Parkin, Councillor Chalmers, Councillor Higgs and Councillor Scalesi. We have replacement members due to attend for Councillor Higgs. We've got Councillor Brand, but he's not arrived yet, but I understand he could be late because he's travelling by train. And we have a replacement member for Councillor Chalmers, who's Councillor Woodliff, and again, he could be late, Chairman. Oh, we've also received an apology from Councillor Woolley. Okay, thank you.
Thank you, and I'd also like to welcome Councillor Robbins to her first meeting. Thank you. Okay, we'll now move into agenda item 2, declarations of members' interest. Do members have any interest to declare at this point? No? Okay, in which case we'll move on to agenda item 3, the minutes from the 15th of February. You'll find these in the agenda pack on pages 3 to 11, and I propose on taking these on block. Do I have a seconder for my proposal, please? Thank you, Councillor Wootton. All those in favour, please show. Thank you. That's supported. Any against? Abstentions. Thank you, Councillor Robbins. Okay, in which case we'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda and supplementary announcements were circulated on the 14th of March. I would like to draw the attention of members of the committee to paragraph 1 of my announcements, which relates to the pre-election period and how the NHS is expected to engage with the committee. Are there any questions on any of the announcements, please? Councillor Cleaver.
Thank you, Chairman. On the question of the pre-election period, I have to say, having checked all of the guidance myself that's been issued previously, in fact, not since the 2021, I believe, was the last one that was issued by the NHS Confederation. There's no reference in it to anyone appearing or speaking to a scrutiny committee. It really relates to announcements of policy and the like. So I'd be very disappointed if there is any interpretation put on the advice such that people don't feel able to speak to us today in any way, shape or form. Thank you.
Yes, thank you, Councillor Cleaver. We have had our own solicitor look into it all, and what is there is factual and what we've been advised, so we can only go along with what is there and obviously try and keep our questions as best as possible. So thank you, but I take on board your comments and I wouldn't actually disagree with you in any way, shape or form. So, in which case, do I have a proposal to note my announcements, please? Thank you, Councillor Linda Wootton, seconded Councillor Ray Wootton. All in favour, please show. Thank you, that's supported. In which case, I'll now move on to agenda item 5, the urgent and emergency care update. This item was circulated as part of the agenda pack on pages 17 to 59. This item updates the committee on the overall arrangements for emergency and urgent care, including both A&E departments and urgent treatment centres. And I would like to welcome our presenter via Teams, Claire Raybould, Director of System Delivery for NHS Lincolnshire's Integrated Care Board. I can hand over to you for a rough sort of 10 minutes walk through the papers and questions at the end, please. Thank you.
Yes, thank you, Chair. Can you hear me okay, everybody?
Yes, thank you.
You can. Great, thank you. As you've said, I'm Claire Raybould. I also have a dual hat that I am the System Responsible Officer for Urgent Emergency Care for Lincolnshire. So that's why I'm presenting this item today. I would usually have brought a clinician with me, but you'll be aware of the junior doctor strikes this week, so that wasn't possible. So you've got a detailed paper in front of you. I'm not going to go through it line by line, but I want to draw your attention to some elements of that and bring it to life a little bit if I can. Firstly, I just want to say to thank all of our health and care partners for all the work that everybody's doing day in, day out across Lincolnshire to support with urgent and emergency care, and also to the public for their support. It's clear that the NHS and care sector has experienced unprecedented demand and sustained pressure over the last year, made more complex by the pandemic and its legacy impact, and that's well documented. In Lincolnshire, we are still in the busiest winter any of us have ever experienced, with record numbers of people attending across urgent and emergency care pathway. That's right from people that need urgent care with their GP or need to go to a pharmacy, right the way through to emergency departments and 999 services. We have seen over winter the twindemic impact of COVID and influenza, and also many other seasonal viruses. You'll be familiar with the strep A that was in the media during the winter, the usual norovirus, and also increase in other infections like scarlet fever that has been the highest it's been since 1950. So all of that combined is really difficult to manage operationally and is very challenging. On top of this, you will be aware that we've had multiple industrial action across the country, but also here in Lincolnshire, both in terms of ambulance strikes, teacher strikes, which impacts our workforce, and also at the moment we're on day 3 of a 72-hour walkout of junior doctors. So that again adds to the challenging picture that's outlined in the paper. In your pack, you've got a copy of the winter plan, which was developed collaboratively across the Lincolnshire integrated care system and has been developed in the context of the challenges that I've just talked about. We totally accept that at the moment, for some people accessing urgent and emergency care service, they will have had long waits and therefore a poorer experience. And with that in mind, back in the autumn of last year, we held a clinical summit with all of our clinical leaders across the system and colleagues from health and care sector to recognise that we knew winter wasn't going to be without significant risk, and how could we create as a safer winter as possible that was clear about that clinical risk and how we were going to manage that across the entire health and care provision, as opposed to it being just sat with one individual part of the provision. Despite increasing those accessing services, as I've talked about, people are typically more unwell at the moment and some require more complex care. So we refer to that as a higher acuity, but basically what that means is people are often more sick than we've seen in previous years. No early evidence around that, but it's obvious, isn't it, with the impact of COVID. That said, though, we've seen some real improvements across urgent emergency care in Lincolnshire, and we're seeing some strong indications of sustainable change as well. So I just want to talk you through some of those today, and that's particularly relevant in relation to ambulance handovers, which I think is what triggered you wanted me to come today, following the update that you had from EMAS previously. So, and I'll talk a little bit about that in a moment. Some of the improvements we've made are detailed in your paper, but I just want to talk about those very briefly. So we've put a process in for system coordination. So that's a national initiative. I think it got talked about as flight deck coordination centres or something at the time they were announced, but essentially it's how we coordinate what's happening across urgent and emergency care within Lincolnshire right the way across all of our provision. We also, that includes patients that attend North Lincolnshire and Goole and North West Anglia, Nottingham. It's not just about the Lincolnshire providers in our county. We work really closely with all of those colleagues with the aim that we try and balance making sure we've got the highest possible of level of care that we can in as safer way as we can, balancing risk decision making throughout the day on a daily basis. And that's working really well for us. It only went live in December. We also know from a pre-hospital care point of view that many people attend hospital because there is no other option often. So particularly when they might need some care that they would be admitted for. So we know that that's an ambition for Lincolnshire. We've shared that with you before, and I know Andrew talked about that when he came to talk to you in December about discharge and flow. So, but we have got additional services now in the community, such as our virtual wards, urgent community response. We have a clinical assessment service that care homes can use if they're concerned about a patient within their home, how they could manage them better without the need to call them into hospital, and our mental health urgent care centre. So I just want to highlight some of those in a little bit more detail if I can. So urgent treatment centres, you will know we have 6 of those across Lincolnshire: Boston, Lincoln, Louth, Gainsborough, Skegness and Spalding. In addition to that, we have a GP-led urgent care service at Sleaford Medical Group in Sleaford that provides minor injury during the day, and early evening provides injury and illness, and all day at the weekends. And we've also got a minor injury unit operated by North West Anglia Foundation Trust at Stamford. In the pack, it talks about urgent treatment centres. They are a real core component of our urgent emergency care provision across Lincolnshire. And it's really important in a rural geography like ours, where we've got levels of deprivation and access challenges. These are generally really busy, these UTCs, in the day, but in the evenings they tend, and overnight periods, they can see as little as 5 patients overnight. So we're always trying to balance that access for those patients in those rural geographies, and the challenge that presents with workforce. We do know that during the winter months, on a small number of occasions, we have had to close one of our urgent treatment centres overnight, typically because of a workforce supply issue. And these decisions are only taken when all other options have been exhausted. So through the process I mentioned earlier about system control, we will look at the balance of risk across all of our services in Lincolnshire for urgent and emergency care as per our winter plan, and we will make a risk-based decision collectively. So no single organisation is having to do that on their own. So it's always done with that in mind, and it's not something we take lightly. We're very clear that if we've said that they're open, they're open. What we do if it does have to happen, is make sure we mitigate that by access, either by a home visiting team, or they can ring into 111, get put through to our clinical assessment service, and then we will identify the next steps for those patients. 2 of the urgent treatment centres, you may remember, are based at the front door of the emergency department. So one of those is in Lincoln, one of those is in Boston. And they're co-located and highlighted as national best practice. So you'll know, I'll talk about a little bit later about the National Recovery Plan. We actually are name checked in there, which is a great showcase for Lincolnshire. So good to see we're ahead of the game on that. In terms of the minor injury unit at Stamford, we're working really closely with North West Anglia Hospital around the engagement of Stamford Hospital Development Project as a whole, and we've been working with them for some time on that. But you will see from the paper that the classification of a minor injury unit really shouldn't exist anymore, and what we're being asked to do is reclassify those either to a GP-led style service, or to a service that is an urgent treatment centre. But you'll note in the paper that the hours of operation and the service that's delivered at Stamford doesn't meet the requirements of a urgent treatment centre at the minute. It's not the only one in the country that's still existing as a minor injury unit. So we're just working that through at the moment with colleagues at North West Anglia Foundation Trust. I also wanted just to highlight the Mental Health Urgent Assessment Centre. The details are in the paper, but that was born out of, we've seen increase in demand going into A&E departments where mental health patients don't have a physical need, but do have a need that could be met outside of that department. So it was piloted, it offers rapid assessment, it's working really, really well. We're working really closely with our police colleagues as well, because they are able to take patients straight there. And that's a really positive development that we have seen over this winter, much less mental health patients that are stuck in our A&E departments, not able to get the care and treatment that they need. And the learning from this pilot will help us inform further expansions across the county, which is our ambition. In terms of ambulance handovers, we know nationally that's been a real challenge. It's well documented in media and in a lot of papers. But I'm pleased to say in Lincolnshire we have seen a significant improvement in our 60-minute delays since early January. This is really important because when a patient is, the poor experience of a patient being sat on the back of an ambulance is one thing, but also it's restricting the ability for the ambulance crew to get out to patients that need an ambulance in the community. So that is a really positive step for us, and you can see the stats of that in the paper. We also have a process in place where if we need to respond to a life-threatening call in the community and an ambulance was stuck outside of an emergency department, whatever hospital that is, not just in Lincolnshire, we're able to enact a rapid handover so that crew can be immediately released. And we've put into place posts that work in conjunction with the hospital and the ambulance trust based in the emergency department that facilitate that happening. So that's been a really positive improvement over winter. You'll note in the paper that we have a new resus department at Lincoln, which is fantastic news for our population as well. That enables a really fast handover and life-saving treatment immediately. And I think Andrew talked about that in December, but it is now open and builds on the phases that we've been doing already with the Urgent Treatment Centre. And you might also be aware that we have had the funding announced for expansion of Boston A&E as well, which is great news for Lincolnshire. In terms of discharge and flow, I'm not going to talk about that in great detail because you had a detailed paper in December, but just to say the initiative that I think Nikki talked to you about and Andrew at the time around Breaking the Cycle 2, which is in the community with health and care providers, is working really, really well. And actually some of the asks of the National Recovery Plan, we are meeting through that work. We've also managed all the various pots of money that we've had over winter in terms of the winter money, the National Discharge Fund that came via the Better Care Fund, and also the additional Secretary of State announcement in January. All of those have been managed through that cohesive joint collaborative working, which is great. And we are seeing improvements in flow as a result of that work, which is really positive. In terms of the National Recovery Plan, that's detailed in your pack and it describes what areas of improvements are needed. I think that plan is recognising we are at a place, aren't we, and that we can't just recover overnight to the standards that we would aspire to. So this is setting us out on a two-year journey to do that. But I'm pleased to say quite a lot of the initiatives that are suggested are either already in place or planned for Lincolnshire. But the key to that is improved integration of services across the NHS, across social care, across the voluntary sector, and obviously with all of our partners. So that is a significant strength for Lincolnshire in the last year, but also particularly over winter. I think that's been a really good strength for us and places us in a really good position to deliver a really great recovery plan for Lincolnshire. On the back of that, we held our second clinical summit strategy day last Thursday to work through our priorities for the coming year as part of that plan. And the ambitions are clearly documented in your paper, so I won't repeat those. In terms of performance, obviously the new targets, the 95% A&E target does still exist, just to be clear, but there is a recovery target now expecting us to get to 76%. So it's been some time since we were at that, as you can see in the paper, but we are actually above the regional average at the moment, which is good. So we are making good progress as a result of the things that we've talked about that we need to sustain. In addition to that, the National Recovery Plan talks about discharge and flow, which I know you heard about in December, but I just wanted to assure you all that the work that has been undertaken through that continues to be really positive in terms of impacting discharge and flow. So that's really good news for our population. So I think in summary, it's been the most challenging period across NHS and care, particularly this winter, for our staff and for the population. None of us like to operate where we're seeing long waits or extended times for care, but I think we've managed it in as safe a way as we can in Lincolnshire. We've been one of the better performing systems as well, regionally and nationally, so that's a real credit to partners across the system. But I think the focus now is how we build upon that and set a sustainable delivery plan for the coming years. So happy to take any questions from that.
Thank you, Claire. That's really helpful. I'd just like to welcome Councillor Brand and Councillor Woodliff to the meeting as well. So, first of all, I've got Councillor White, please.
Thank you. In order to maintain the flow, you've got to have some kind of control over input and discharge. And I'm interested in whether you're collecting data into who arrives at the urgent treatment centre. For example, some people may know it's the right place to go. Other people might have been referred by a GP. Other people might have tried to get an appointment with a GP and been unsuccessful. And then some people might decide that it was a waste of time trying to get an appointment with a GP. I'd just like to say, I don't think these urgent treatment centres are very well known with residents, and I think we need some kind of guidance as to where you should go. For example, in the past, if you had a fall and after a few days you're still feeling pain, you thought, oh, I wonder if I've broken anything, you would usually go to the GP and get a referral for an X-ray. Now, I know from one example that one person went through this Ask My GP process, didn't want to bother the hospital service, and was referred to the urgent treatment centre. So I'd just like to know, are you collecting data on why people arrive at the urgent treatment centre, please?
Yes, absolutely. We do collect that information, and we do review the information about where our patients present right across services in the county. And part of the clinical summit that we had last week, we had those conversations about how do we help the public understand. It's really complicated, isn't it, urgent care in the NHS? And that's why we do push 111 first, because that can navigate then from there. But it is complicated. We recognise that. But yes, we do collect that data, and then we do act upon what that tells us if we've got a clear and obvious pathway that's not working, and then we would take corrective action in that regard.
Thank you. So where would you go if you thought you needed an X-ray then? Would you go to the GP first?
Well, you could do either. I think in that situation, it depends really. If you're in pain, and then I would say go to your urgent treatment centre. Either way, they will be able to help you. If you're thinking you need an X-ray, obviously we don't have X-ray facilities in the GP services, but they would refer you. So they'll be able to book you an appointment in the urgent treatment centre. So either one of those would be okay in the example that you gave.
Thank you.
Thank you. I've got Councillor Raywitton.
Thank you very much, Mr. Chairman. Good morning, Claire. Looking at your page 27, your 4-hour performance figures of 71%, that must leave thousands of people who are attending A&E emergency department who wait longer than a 4-hour period. Now, for myself, I waited 13 hours last May in A&E following a stroke. And one of our colleagues from County Council here waited 30 hours, and lots of my residents are also waiting longer than 10 hours. Can you tell me what plans you've got in place to turn people around and get them admitted quicker? Thank you, Joan.
Thank you, Councillor Wootton, and nice to see you. So, yeah, you're quite right. Then clearly, conversely, 29% of the population are not being seen within 4 hours. So, and we do have some examples of extreme long waits, as you've described, and we do keep a track of those through our system coordination centre. So all of the work that we're talking about in the paper is designed to provide alternatives to people that don't need to go, so that the people that do need to go can be seen quickly. We know we've had a real challenge with discharge and flow, which you've heard about. We've had a real challenge with the level of demand, but we also know we haven't historically had a lot of services in the community. So the only option has been for emergency departments. We've now got same-day emergency care. We've got urgent response in the community, and all of those are now starting to reduce the demand that goes into the emergency department so that we can see and treat people quickly. But I think there is no silver bullet in terms of getting back to the 95% standard in the short term, because it requires us to recruit to some of these new services and build our workforce. And that's why I think nationally the target has been set for 76%, because it's recognised that that actually is achievable, and there's really good examples of how you can do that across the country. So it's a combination of factors that will enable us to get there, Ray, not any one single bit.
Thank you, Claire. Thank you, Sharon.
Thank you. I've got Councillor Loughagan.
Thank you, Chair. Yeah, and thank you for your report. It was very informative. I just wanted some more detail about the discharge delay. You said that there have been improvements, but I haven't seen any numbers about how that's happened or how many people are now being discharged more speedily who don't need to be in hospital. Thank you.
Yeah, thanks. I didn't put the data of that in the pack because I know you had a comprehensive update in December, but I'm happy to share that with you, Chair. So what we're seeing, so we monitor discharge on a daily basis. So as I speak this morning, there will be a call ongoing across the health and care system that will set out what the target for discharges is for the day based on the demand that has come into the hospital, but also the patients that are in hospital and their planned discharge dates. So that target is then worked through with all of the teams all throughout the day. And what we're seeing is, if I think back to probably December time before we implemented a lot of the changes, we were trying to discharge over 200 people a day some days, you know, significant numbers. Now, often this week's slightly different because we've seen very increased demand this week. But if I just take last week, we were getting down to sort of 110 patients a day. So we've significantly reduced the people that are delayed. And I think Andrew spoke last time, particularly about those that have been waiting for discharge for a long period. So we are seeing those numbers come down, which is really positive. But it's such a fluid situation, and you can look at the data at any point in the day and it will tell you a slightly different story. So it's quite complicated, but we are definitely seeing an improvement in our discharges, which clearly will be helping patients because we know they decondition when they are in a hospital bed when they don't need to be. I have an example of a family member last week who needed to be discharged and they need to get home and they need to get mobile and get back to their normal how they normally would live their lives. But the longer you stay in hospital, the worse that is. So we are seeing that evidence, but it's quite difficult to display. But I can give that some thought and pass some information over if that would be helpful.
Thank you. Sorry, thank you. Yes, it would.
Thank you. I've got Councillor Allen next, please.
Thank you, Chairman. Thank you, Claire, for the report and the presentation. I think it's important to recognise that there are some improvements taking place, and indeed that Lincolnshire perhaps isn't as poorly rated as some other trusts across the country. Maybe that's because the population of Lincolnshire is a stronger type of person and doesn't always cause some of the problems that may occur elsewhere in the country. I've got some comments to make, though. The recovery plan always seems to go back to the worst situation within the COVID situation, and look at recovery from that. And to a certain extent, I would expect that is something that we must do, and something that might be relatively easy to do once the COVID type aspects can be ignored. But recovery, in my sense, means really, going back to the situation. To the more historic situation that perhaps existed within the health service prior to COVID, because that seems to me where we ought to be targeting. It's what was happening before COVID caused all the problems, and indeed improving upon that situation rather than improving on the worst aspects of the situation within COVID. And that information isn't really available in the report itself. It's always looking at what was the worst situation and recovering from the worst situation, which should, to a certain extent, be easily achievable, you would hope, once COVID has disappeared. But we have to get back to the situation pre-COVID if we're actually going to provide real improvements within the service that the NHS provides. And indeed dealing with some of the aspects that come from that. And that's generally, I think, rather than just accident and emergency. The comment's been made that whilst there has been improvements in the way that we're perhaps looking at dealing with the accident emergency inputs and outputs, there's still a lot of issues, even in Lincolnshire, that need to be addressed because there are many people who are suffering the consequences of progressing through the system. And with many more hours waiting there the 4 hour that we're talking about. And I always have some reservations about targets that have been set that are achievable as opposed to targets that have been set that actually are likely to create improvements or actually provide real motivation. So that's my comments, Chairman.
Thank you for your comments there. If I could just make a couple of observations. I think you're quite right about the recovery plan. What I would challenge is that I think people think when COVID is gone, i.e. the impact that that directly has on not having to manage infection prevention control, not having to manage people with COVID in services, then it's over. There is a legacy impact on COVID. So you will be aware that we have people waiting for operations, we have people waiting for appointments that they didn't have during COVID, and they're not, it's always been stated that's going to take a couple of years to resolve. So whilst those people are waiting, they will often access urgent and emergency care, and we know that, and we're starting to do a lot of work about how we can target those with greatest health inequalities and all of those sorts of things. So it is, just be mindful, it's not just the impact of COVID and it's gone away, that clearly we're living with that now. It is the impact on the health of our population that is presenting some challenges, and I think that's what they mean in the national plan. But having said that, we in Lincolnshire, when we had our clinical summit and strategy day last week, were very clear that our ambition is greater than what's in that plan, and picking up your point really. So where we can go further faster, then we absolutely will. But the reason you've not got that information is because we haven't written our plan yet. So this was published on the 30th of January. It's only 6 weeks old. We were already in progress, as you'll see from my paper. We had a summit last August, we had a follow-up summit last week, and that work is already in train. So once we've written that plan, I'd be really happy to come back and talk about what that says. But I think let's be under no illusion that this is really, really difficult and challenging work that we've got to get through. We've got significant workforce challenge across health and care, where people are finding it easier to work in other sectors than they are in the care and health sector, and all of those things do add to the complexity that we've got and our ability to revert back to where we were really quickly. But be assured that our ambition, and there was a very clear commitment from sort of 70 people in the room last week of our clinical leaders, that we must go further faster for our population. Thank you.
Thank you, Jim. If I just come back, I certainly wasn't implying that there was that the effects of COVID could be ignored. I was just suggesting that perhaps we need to look more historically than the situation within COVID itself. And I know that there's ramifications going forward in relation to the recovery plan as well, because there is obviously a lot of people who didn't seek help, healthcare help during COVID. We were instructed not to do so. If I remember rightly, and that has got a consequence in terms of then people coming for the support that they didn't get during COVID, and indeed a more greater degree of help perhaps than would have perhaps been the case if they'd actually gone at a normal time during COVID itself. And there are ramifications, I think, even now as a consequence of that, as we're seeing in excess deaths figures as well. So I certainly wasn't suggesting that, but I was suggesting that we need to look beyond just simply recovering from the worst consequences of COVID. We need to get to a situation where there's genuine improvements in the healthcare of the population, and one that they did exist before to a certain extent, before the waiting list started increasing. And that's what we must do, I think, if we're going to actually address the situation regarding some of the consequences that came out of the past 2 years. The only other thing I would say is that we're probably now a year into the recovery plan period, I think, with some comments being made about how quickly we could get to a situation where we have recovered. And it seems as though it is taking quite a long time. I think the 2-year aspects that were mentioned, I think, in terms of having some sort of impact on the waiting lists, don't seem to be coming forward as quickly as perhaps everybody envisaged.
I could just comment, if I may. You're right. I think there's different recovery periods. So there's a recovery period for elective, which has different stage targets, and then there is the recovery period for urgent emergency care. Clearly, this recovery period we're talking about for this plan that was launched 6 weeks ago is 2 years from now. But like I've said, we've committed in Lincolnshire that we will do everything we can to recover as quickly as possible. But that does require some of the other areas of recovery across Lincolnshire, with my day job hat on, that need to come together, and we're absolutely doing that.
Thank you. Councillor Cleaver.
Thank you, Mr. Chairman. 2 points, if I may, please. First of all, I think we're all aware that both the general public and the NHS itself are increasingly reliant upon the 111 service, which is, and increasingly so. So I wonder then, in relation to people accessing urgent and emergency treatment, whether the appropriateness and the quality of the advice given by 111 is monitored and audited. And if it is, do you think that's done appropriately, please? The second point is in relation to the minor injuries unit at Stamford. And I would point out that when the CEO of North West Anglia Foundation, NHS Foundation Trust, spoke to us in January, she made it clear that NWAFT was awaiting a decision by the ICB as to what they wanted to fund. Now, that message is slightly different from what you've said in your report and what you've said to us today, which is that you're continuing to work closely with them and you're trying to work it out with them. So can you just be clear on how far you are with deciding what you are going to fund as the future arrangement, and if and when that plan will go out to public consultation, please? Thank you.
Councillor Cleaver, I'm just going to push back a little bit, and I hate doing it, but because we're in Purda, I'm not sure how much can be said in terms of what's happening with Stamford, because it isn't something that's gone out to consultation or anything else there. So I don't know whether or not one of our Claire can respond to this, but I would like to. I'll let Claire say what she feels.
Yeah, thanks. Thanks, Carl. So firstly, on the 111 reliance. So yes, we do monitor and order an audit. Sorry, 111. What we do also have in Lincolnshire. So we have 111, which is the front door, if you like. Then we have a clinical assessment service, which is operated by our Community Health Trust in Lincolnshire. So where it's obvious what needs to happen, then 111 will deal with it. So, an ambulance required or whatever. Where they need further clinical assessment, then they are pushed through to our clinical assessment service in Lincolnshire. So that's a Lincolnshire service that understands the pathways of Lincolnshire, and we do audit and monitor that as well. And we are seeing increased numbers now coming through into our clinical assessment service in Lincolnshire, which is absolutely the right thing to do. So that's that point. On the minor injury unit, what I will say is that there's been no question about funding. We've not had a discussion about that. What we have discussed is how do we move from the minor injury unit currently has a classification that technically doesn't exist, but we know there's still quite a lot of them across the country. What are we going to do in the future? And that's been part of an ongoing discussion that we've been having through the Stamford Hospital redevelopment project. So there isn't a question about funding. That's not the issue. It's about the classification of the service. So we already pay for the service. It's in our books, if you like, and we pass that money over to NWAFT. It's about the classification. That's the issue that we need to work through jointly together with the trust. And there's been lots of conversations about that in the past. So I don't think at this stage I'm suggesting that anything's going to consultation. We're just working through that process. So that's probably what I can safely say, Carl, if that's okay at the minute. But there isn't anything hidden within that. That is where we are.
Thank you, and we'll certainly bring it back anyway when there's more information. It's something we want to keep a watching eye on. So, but thank you for the question. I've got now, Dean next, sorry.
Hi, yeah, thank you very much, and good morning, Claire. I just want to add to what Councillor Wootton mentioned earlier on in terms of what work's been done around sort of harm reviews and the effects that waiting over kind of 4 hours is having on people's health. waiting longer than the 4 hours. So just wanted to understand what's being done around that.
Yeah, certainly. So in terms of in terms of how we monitor harm, there's really set processes in place within acute trusts about how they do that. What we're really clear about is how we monitor the patient when they're sitting waiting in a department. Same if they, in the past when we have had long waits on ambulances, as we've heard, there is a process in place to monitor harm and make sure patients don't deteriorate during that period. And that's exactly the same in hospital emergency departments and urgent treatment centres, or where patients are going over what we would say is a reasonable amount of time. I think the key thing about emergency departments, when patients wait over 4 hours, generally speaking, it's because we haven't got a bed. So a decision will have been made that the patient needs admitting, but we haven't got a bed for them to go into. And that's because we've had problems with our discharge and flow. As I've outlined, that's really improving now. So we should start to see that position improve, which is why, whilst the national ambition is 76%, we want to try and get further faster. And our medical director at the Integrated Care Board set out that really clearly at our clinical summit last week about how, the harm that can come to patients for every hour that they're sat waiting in emergency departments. So we're really clear that that's our ambition that we need to achieve. But in short, yes, there is monitoring done through provider trusts.
Thank you. I've got Councillor Brand.
Thank you, Chair, and good morning. Back to the UTCs and a couple of questions, if I might. We have data for the 6 centres run by the Trust. In Sleaford, of course, there is a centre run by Sleaford Medical Group. So the first question is, do we have data for that service? And the second question is Sleaford Medical Group, when they run it, required to follow the standards which are set out on page 21? Thank you.
Yeah, thanks for your question. So firstly, yes, we do have data on Sleaford Medical Group. Yeah, we can tell you the numbers that go through that service. It also gets used almost as a bit of an out of hours point of contact for people in Sleaford as well. So so it can be skewed a bit data wise, but yes, we absolutely do have that. In terms of against the standards in there, they're not, because it's not an urgent treatment centre. So it's a GP led service, and you can have those so that offer either minor injury or minor illness and minor injury. So at the moment it does it's always had a minor injury service that operates from 8 till 6. And then several years ago, I'm probably going back about 7 or 8 years ago now, we put in a minor illness service as well in the evenings and at the weekends, recognising the geography, and it was a part of the patch that we didn't have covered by urgent treatment centres or other services. So that's what it does. So it doesn't have to meet the definition of an urgent treatment centre because it isn't one, and it wouldn't, and because it's a GP-led service. So hopefully that helps answer that.
Thank you for that. So I'd certainly welcome the data. Since it doesn't have to conform with the national standard, presumably you have set a standard, since you presumably will be funding this, I assume.
Yeah, that's right. So they do have standards set in their contract about how quickly they have to see people, and actually the service is really very good and scores very highly on all of those key performance indicators. So, but its footfall is much smaller than the urgent treatment centres. So, but yes, it is a slightly different nature.
Thank you. I've got Councillor Smith, please.
Thank you, Chairman. And it's just to go back a bit on what Councillor Allen said and expand on it, as he sort of alluded to. There has been a problem before COVID. Just before COVID hit, our waiting list started to rise for one reason or another. Obviously, COVID hit, so we never got down to the bottom of why. At that time, those waiting lists weren't small. They were substantial, but they were of a size the NHS could deal with. Chairman, I know this has been raised on the floor of the House by my MP. There is a question, and this is no reflection on those that work in secondary care, but there is a question of, is the system that the NHS is based on actually sustainable in its current guise? And I'm not, before somebody from the Lincolnshire or anywhere else says, I'm not proposing an American system or anything of that nature, but as my MP has alluded to, these systems, the similar systems that they use in Europe, because they seem to get better outcomes, they are seen quicker, and waiting lists go down quicker. Now, as I said, this is no slight on people working in our NHS, because they're working flat out, they're working very hard. But when we pump 40% of GDP that we get as a nation into the NHS, and we constantly hear, we need more, there's going to come a point the government can't give any more because it's not got any more. But people will still need to be seen, people will still need treatment, they will still need operations, they'll still need to go to A&E, they'll still need all these things. And my final point, Chairman, and this probably isn't a popular one, the National Health Service, we're quite fortunate, I think, in our part of the world, but in other parts of the country has become the world's health service, and people who are not British nationals are using our health service and not paying for it. Whereas if I went abroad and I needed health care, I would have insurance or I'd have to pay for it. And until a similar system's put in place, you will have a feeling from some residents, rightly or wrongly, but you will have a feeling that they are paying for a system and being put to the back of a queue that they have paid for the last 30 years. Now, I'm not saying that it's right, I'm not saying it's wrong, but that is a feeling that I increasingly am being made aware of, even in my patch, Chairman, and I think we need to be cognizant of that. Thank you.
Thank you, Councillor Smith. I'm not overly sure that Claire's going to be in a position to respond to any of that, but thank you for your question. I've got Councillor Harrison, please.
Thank you, Chairman. I'm particularly interested in the urgent community response system, how it actually works, whether they're only referrals from 111 or whether they're also 999 calls, and where the team that do this response, are they all over the county? Do they have a headquarters? How do they split in with the rest of the system, please?
Yeah, thank you for your question. So the urgent community response is they're a roaming team in effect, because they spend most of their time responding to patients right across the county. I'm sure they do have a base where they start and end their day, but they're predominantly they're roaming and dealing with responses. They're part of the integrated urgent care service that Lincolnshire Community Health Services run, and they do take referrals from right across the system. So a GP could refer into them. If a paramedic is with a patient that's had a 999 call and actually it's appropriate for community response, they can refer into them. Similarly for district nurses or adult social care. So there is that opportunity there for and also for 111 because it would go through to our clinical assessment service, and then they would dispatch, if you like, urgent community response. So that's how it works. It covers the whole of the county from a geography point of view, but they don't have a specific base that I'm aware of. I think they probably just start and end their day from wherever is their normal base, but they're out and about most of the day.
Thank you.
Thank you. I don't have anyone else that's expressed to. Councillor Woodliff.
Thank you, Chairman. I just wonder whether there's any stats on the ranges of age of people who use the services we've mentioned. Councillor Smith mentioned that 40% of our GDP goes on National Health Service. I wonder whether they have any stats as to which particular age range benefits most from the NHS and these particular UTCs. Do we have any stats on that? Because it might well be that my age range benefits most from this rather than the youngsters who come in from abroad. Do we have any information on that?
Yeah, in terms of access to our services, obviously we do collate all that data by age. I would say for a lot of our urgent and emergency care services, it's probably the frail older population that do tend to use it the most if you were to cut it by age band. But also, you will get, it'll be different at different times of the day. So early evening, you'll get a lot more children because they've finished school and a bit unwell. And leave it till sort of the early evening before they access a service. In the day, that might present differently. So we do collect all of that data, and it's part of what we use to plan the workforce to make sure we've got the right skill mix in our services at any one time. So yeah, that's absolutely the case.
Just want to make a comment. Do you think perhaps we're all living too long? Is that our fault? We're living too long.
Absolutely not. No, I think, yeah, you know, clearly in Lincolnshire we have got a growing older population. The priority for us in Lincolnshire, I think, and this has been discussed through Health and Wellbeing Board and other areas, is to do more work around prevention. So we know that a lot of people access services quite late in the day, and particularly in deprived areas. So there's clearly lots of work that we can do about that. And as part of our summit last week, we actually looked at that, the balance between where you live in the county and your access to services, whether that's planned or unplanned. Because just to reiterate, for urgent and emergency care services, they can be a receiver of something that's happened elsewhere in somebody's life cycle, and that could be a social issue, a housing issue. It's a whole raft of things. So, but we've got to get better at prevention, and that's something I think the Lincolnshire integrated care system as a whole is really clear it needs to do work on.
Thank you very much, Chairman. Thank you very much indeed.
Thank you. I've got Councillor Linda Wotton.
Thank you, Chairman. Good morning, Claire, and thank you for your informative paper and for your presentation this morning. It's obvious to me that the Mental Health Urgent Assessment Centre in Lincoln has been a great success that you've been piloting. In your paper, you say that it could be expanded to somewhere else in the county. Are you able to share where that might be, Claire? Thank you. Thank you, Chairman.
Yeah, I think based on data of presentations out towards the east, so probably around Boston would be where you would next site one. But there's been no decision about that and no firm commitment to that. But clearly, from what we've seen and the impact that it has on A&E, but also on our police colleagues, the more we can do around that, the better. So we will map it where we've got the big incidences of those going into emergency care, but also into crisis care in the community. So it could be a really positive step across the county as we go. But if I was to guess, I would say, based on the data I've seen, Boston would probably be the next place you would put one.
Can I just add on to that? Are you aware of any timescales currently for that rollout?
No, really, we've just been talking as part of winter plans, so quite live, really. So just in the last week or so, as part of our review of winter and then looking at what we're planning for in current years, we've just been clear that has to be something that we need to work towards. But that will require capital investment, and it will require a full business case to be written. So I think we're all agreed we need to get to that place, but obviously we haven't done that yet. So I would expect that this year will be further down the line in terms of what we want to do and where. But I couldn't give you an exact time at this point.
No, thank you. I think that was helpful just to sort of get a rough idea. I've just got 3 questions, if I may, and then I'll move to a proposal. So my first question is, how well has the winter preparedness plan worked so far this year? And do you think Lincolnshire is over the worst of the pressures for this winter?
Okay. I think the winter plan has worked really well this year. I feel quite proud of how we've come together as a health and care system right across our voluntary sectors and our care sector, as well as traditionally NHS. I think we've got a bit of a legacy, haven't we, of planning individually, either in the NHS or in social care or in other bits. And this has been a true collaboration across the system, which I'm really proud of. So I think as a result of that, we've managed winter really, really well. If you take the Strep A as an example, when that hit, nobody had predicted that or knew what to do. We worked really closely with public health colleagues in the local authority and all the NHS partners and our GP practices to come up with a solution about how we could manage that really difficult issue that we had and try and support families in that situation. So yeah, I'm really, really proud of it. Sorry, what was the second bit of your question, Chair? I've forgotten.
It was, do you think that Lincolnshire is over the worst pressures for this winter?
Sorry, yes. I think we're getting towards it, but we are still experiencing peaks in demand, which is not unusual. When you get a really cold snap, you do end up with an increase, several days later into services. And certainly this week, Monday, we've seen demand that we haven't seen for the last 4 weeks. So I wouldn't say we're over it, but we're getting there, I think.
Thank you. My next question is, looking forward to the next cycle of winter planning, what sort of an effect do you expect the lack of additional funding that was given for 22-23 will have on your services and planning this time round?
So unfortunately, this time round, we have been given money ahead of next year for what we call demand and capacity planning. So we've been given our allocation for next year already, so we know what that is, and we're starting to work through that. It's not as much as we need. Certainly, it's not double what we got last winter, and therefore it's for the 12-month period. It's not quite where we would want it to be, but we are prioritising that as best we can so that we make best use of the money that we've got, and we're planning that now. So all of the services that we put in place this winter, if we need to keep them throughout the year, then we are, but we might be lowering the numbers of them. Active recovery beds is a good example of that, where we are going to continue with them, but we don't need the level that we have in winter all year round. We need to step them up in winter. So things like that we're already planning. So I think we're in a good space from our planning for winter, and we'll have that planned in early. And also then, if we continue in the way that we've worked this winter, we'll have the ability to manage these issues that pop up out of the ordinary. But yeah, any more money is always welcome for urgent emergency care.
Thank you. And my final question is, how has industrial action impacted on emergency and urgent care?
It's had a huge impact on urgent and emergency care. So clearly on the days that we've had the ambulance strikes, for example, that has impacted. We've had to put plans in place to manage the emergency pressure, but that results in us cancelling activities in other parts of our health and care system, which isn't helpful, because that just adds to the recovery that we just talked about earlier that we need to do. So it's not been helpful. This week in particular, the junior doctors strike, they are a huge percentage of our workforce, and a really important part of our workforce, and a very skilled part of our workforce. So the impact of not having them has meant that we've had to, stop some services, and we have had to postpone some people's appointments. But from an emergency care perspective, just this week, so I've just talked about Monday, we saw record levels of demand. That was really challenging to manage without that additional workforce in place, and did lead to some high numbers in our emergency departments, and has not been able to maintain quite where we've just talked about of the improvements that we've done. So it is a huge impact upon us, and also the planning for those takes away the very resources that we need to be doing the recovery work that we've just talked about when we're having to plan for the next strike. So we're already in planning today for the ambulance strikes that are still due to start on Saturday.
Thank you, Claire, and thank you for your presentation, in which case I'm going to make a proposal that we note the winter preparedness plan for 22-23 and to welcome all the initiatives improving urgent and emergency care for patients, including the new resuscitation department at Lincoln County Hospital, the improvements in ambulance handover times since early January 2023, and improvements in discharge and flow of patients, and also to put on record that the committee would wish to see NHS Lincolnshire's Integrated Care Board consulting with the committee on the future of the minor injuries unit at Stamford and Rutland Hospital as this moves forward. Do I have a seconder for my proposal? Thank you, Councillor White. All those in favour, please show. Thank you. That's supported unanimously. And thank you, Claire, for your attendance today.
You're welcome. Bye, everybody.
Bye. Take care. Thank you. We'll now move on to agenda item 6, the Lincolnshire NHS People Strategy for Recruiting and Retaining Talent. This item was circulated as part of the agenda pack on pages 61 to 76, and this item provides an update on the strategy. I'd now like to welcome our presenters. I've got Kerry Lennon, Senior Responsible Officer for the Lincolnshire NHS People Board, Director of People and Innovation for the Lincolnshire Community Health Services NHS Trust, Samia Hebar, Associate Director of People for Lincolnshire's Integrated Care System, and Wendy Cundy, Primary Care Workforce Lead for NHS Lincolnshire. If I can hand over to you just for a sort of 10-minute walk through the paper and then questions at the end. Thank you.
Good morning. Thank you, Chair. So my name is Kerry. As I've just been introduced, I don't need to do the first bit, but lovely to be with you again this morning. So we joined you in July last year and shared with you a number of things. We shared with you what we had learned from COVID regarding how we work better together across the health and social care workforce, how the NHS trusts, the 3 trusts, were really starting to collaborate on the many workforce challenges that we shared with you last time that you'll be fully aware of. We also shared with you the working with and the learning from our primary care colleagues and our colleagues in adult social care. And that was a real emerging piece of work that we could share further with you today. And then we shared a number of ambitions to transform how we build and, more importantly, how we retain our people and a sustainable workforce in health and social care across Lincolnshire. So today, as we sit here, it is an equally challenging landscape. I'm sure you've just heard from a previous presenter the challenges we're facing. However, today we do provide an update, and I'll invite my colleagues shortly to share some thoughts as well. So we will just spend maximum of 10 minutes and then obviously open for questions. So the update, we're assuming the paper is read, and there are a number of attachments as well which might be helpful for you to read. We will pull out the key pertinent points. We'll show you some trend data. It is very high level. It's not, it shows some positive trends, and it is very high level. We're working towards a better level of sophistication, and we're working with partners within NHS England to do that. But that's a work in progress we will share with you, because it's really important that we're able to evidence the progress we're making. So we will outline some current plans for 23-24 and beyond. We'll show some slow progress, showing lots of work still to do, and strong collaboration with, now we have some dedicated resource with us to support us on that journey. So I will just kick off with talking about the vacancies. So the current position is on 62, I believe, of your pack. We're starting to see a downward trend, which is a really positive trend. We have some spikes, and the spikes that you will see are where establishment has regrown because maybe of further investment or the like in some really key areas or in certain organisations. The trend is positive, but as I said before, we've got some way to go. We were asked to provide some comparative data because it's really important. If Lincolnshire are showing a positive trend, how are our counterparts doing elsewhere? Well, unfortunately, we don't have the published data is dated, and so therefore we're unable to show like for like at the moment. However, we're working with, again, colleagues in NHS England to be able to provide that, and so that's it. Will probably within the next 6 months we will have that ability to see like for like. So what are we doing about vacancies? We talked previously about an attraction strategy, and on page 63 there's some mention of the strategy itself. So talking about domestic recruitment first and foremost, we've now partnered with a digital marketing partner, and we're really focusing on localities within Lincolnshire, and this came as well for some feedback from last time I met with colleagues in the room today, and really Councillor Chalmers was fantastic at inviting us to Boston, and we spent some time and looking at how do we really provide some opportunities for people to work in health and social care from that locality. So we're going to see more of that in this coming year. So scaling up international recruitment, a lot of the vacancies that we have filled have come from an international route, particularly into the acute and mental health trust, but also now into the community. We're now starting to look at pipelines, and we have got some positive pipelines into primary care. And then for next year, and then I'll pass on to Samia shortly, is the Rural and Coastal Programme, which you'll see on page 67. So in 22-23, we piloted alongside 4 other similar footprints across the country with Health Education England funding to really look at how do we invest in rural and coastal communities, and digital inclusion was one of those areas. It was about inspiring the next generation, those children and youngsters that are growing up within the county. How do we retain them in the county? So we've done some pilot work, and we've got some work to do this coming year, and we've got some promise of further investment to do that, which is fantastic. And working alongside partners in Mablethorpe with Campus of Future Living is a really key area for us. working with, we'll talk later about the profile of the workforce in primary care, and really maximising advanced clinical practitioners. So these are nurses and other practitioners working at the top of their licence, so able to work autonomously with patients. And other work around the rural and coastal programme. So I can talk, and I will stop right now, and I will hand over to Salmia first and then on to Wendy. Thank you.
Thank you, Kerry. So I'm Salmia Hebar, the Associate Director of People. And the last time I joined this meeting, I was literally a few weeks into post. And there was a question around, it's great to see the start of the thinking and the ambition, but can we please see some deliverables, achievements, a realistic plan about what we want to do. So one of the attachments that we have provided is the delivery plan. So it's not high level, it's actual itemized projects that we have achieved this year. Some of them will continue into the next year. Things like retention, for example. We were one of the chosen People Promise Exemplar program sites, and we've seen huge benefits of being part of that program, of using the national framework, customizing it for Lincolnshire as a region, and implementing some real good practice here. We've shared some of the data in the paper around the increase in staff engagement scores, in the reduction in turnover, which we've started to see over the last 3 or 4 months. And this will continue, the focus of this will continue into next year. We have some pilot projects in place, things like stay conversations, trying to catch people before they think of leaving, so that we can retain them within our partner organizations, within the NHS, primary care, social care even, before they move out of the health and care sector in total. We've also done a lot of work on the workforce planning tool. So the last time we came, we touched upon this very high level because it was an ambition at that point of time, but we have progressed quite a lot. Lincolnshire is one of the first ICSs in the county, in the country, to take a look at this. And the aim is that we can actually tie in the data so that we're able to project workforce demand in the future and link it to key pieces of clinical work. So if there's an increase in beds, what's the increase in workforce that we're looking at, etc. And that sophistication of data, as Kerry said, is really unavailable to us right now. It's currently for the acute hospital, the community hospital, and mental health right now. But if it works, and we're very hopeful, then it is something that we're looking at extending into primary care as well in the coming year. Kerry spoke about the rural and coastal program. That again is a huge part of our ambition for next year. For example, we've done pilot programs around digital coaches. How can we really work not just with our workforce, but also with our community, coaching people, building the confidence in using applications, digital technology to enable better patient care. So, those are just some of the projects that we've highlighted. But like I said, the detailed project plan of what the People Plan covers at system level has been shared with you as an attachment. And I'll hand over to Wendy to talk a little bit about, workforce and the workforce strategy for primary care.
Thank you, Samia, and good morning, everybody. My name's Wendy Cundy. I'm Head of Primary Care Workforce Transformation. I think it's fair to say we've got similar challenges in primary care with attracting, recruiting and retaining our workforce. We've got an ageing workforce, and we've got a very diverse landscape in terms of general practice, with 81 practices working within 15 primary care networks, which is great because we've got primary care networks to engage and communicate with and hold the ring on that. But there's a huge diversity within that in terms of patient needs, delivery, employment models, terms and conditions, and over general practice, we've got approximately 2,500 staff. So that's quite a big collective of staff. I think one of the things that I really noticed when I came back to work in primary care last year was the additional roles. At one time it would be your GP, your nurse, probably your dispenser, your receptionist. And now we have lots of different roles. I think there's 16 extra roles, care coordinators, first contact physios, I could go on. So that's a real different landscape, and it does provide us with some opportunities. So last year when I joined the people team, working with Dr. Kevin Thomas, who I think has been to the Scrutiny Committee before, he's one of our clinical directors and the workforce lead in the Primary Care Network Alliance. The brief was to build capacity, and that's what we're trying to do in primary care. So there is alignment with the system people plan. We established our primary care people group just approximately a year ago. And I'm pleased to say there was a meeting yesterday and we've just agreed our first collective primary care people plan. So that's a real step forward. There's a work programme that supports that, and our first year priorities I can share with you. So first thing is to address critical gaps. I think everybody would agree that is definitely a priority. Trying to get good data sets is a challenge, but we're trying to do that and trying to identify pipelines of where we get our staff from. Then we're looking at a deep dive into attraction, recruitment and retention activities, because again, there isn't one method. There probably shouldn't be. We all do things differently. There's certainly a lot of innovation and experience out in primary care. So we're trying to just sort of harness some of that and look where we could work collectively again on some of those activities and support our primary care colleagues. The third priority is to co-design and enable the PCNs to evolve into neighbourhood teams. That's part of the Fuller report recommendation as well. And lastly, to support primary care to be a great place to work, where individuals can really reach their potential. So I think that's important as well. We don't need, we shouldn't lose sight of that. We've had some really good communication and engagement with the plan. And it is ambitious, and when we sort of break it down into activities within our work programme, we may need to say, well, this is really high priority, and that probably is going to have to wait till year 2 or year 3. But I think I'm hopeful that we've got the target right, really, with those first year priorities. Just one factor that you might be interested in. From April, we do have our community pharmacy, dentistry and optometry colleagues joining us in primary care. So that will be the 4 pillars of primary care working together. They're all at different stages. Some of them are NHS employees, some of them are private concerns. Again, that adds another layer of diversity, really. But we're already seeing the benefits. They're already part of the group, and we're already seeing the benefits of working in partnership. So I'm quite happy to share the plan with yourselves. It will be ready in PDF format next week. So quite happy to send that forward if you would like to see that. And I'm quite happy to take any questions. Thank you.
Thank you. I've got Councillor Allen first.
Thank you, Chairman. I had to revise my questions, if that's all right, on that last comment about integrated care systems and the dentistry, ophthalmology and pharmacy that we heard before. And I think a comment I made at the time, I'm not too sure how you can integrate dentistry part of that into integrated care when it doesn't really exist in Lincolnshire. But, that's a throwaway comment to a certain extent. The real question I've got in terms of the paper that's been presented to us, and thank you very much for doing so, because it's got a lot of interesting items in it, is that we are making an impact locally, and this is really what my issue is. It's locally. We are making an impact on the vacancies that we've got, which seems to be one of the main things that we actually monitor. And certainly in primary care, we had a paper a few committees ago which said there's been substantial recruitment into primary care so that the support staff for the doctors and the GP practice provisions that take place had taken place, and there had been a substantial increase in terms of the resources employed in the primary care system. I have a feeling they probably all came from the NHS. In terms of the mainstream resources moving across from secondary care to primary care, but that's something that perhaps other people know and I don't. So we can recruit when we put the effort into it, I think, because the graphs that have been presented to us show this, and I say the early report about the doctors' staffing arrangements also show that. But the concern I have is that we're talking about the National Health Service to a certain extent and the sort of Lincolnshire delivery. And what worries me is that whilst we perhaps have some idea of what's happening in Lincolnshire, we don't have any idea really. We're rarely presented with anything that shows what is happening within the National Health Service as a whole. I can't see how Lincolnshire can operate entirely independently of the National Health Service that operates within the country as a whole, because to a certain extent there's an existing pool of resources, and as I mentioned with the GP recruitment plan, it seems as though you recruit within that pool of resources, and the pool of resources to a certain extent then moves around the system, either filling in new posts or moving to slightly different areas, you know, where they can get a promotion perhaps, or more interesting work or whatever. And overall, across the country, and perhaps even across Lincolnshire, if you look at it in that sort of way, there's never a real increase in employment. It's just employment moving around the system, and some people gaining as a result of that, and some people losing it as a result of that. And what seems to be missing from this is somebody that actually looks at the whole of the system and says, this is what we need, and this is where we need it, and this is the sort of specialities that we need, and this is what's going to happen over the foreseeable future in terms of the resources retiring, and in some circumstances you being, you know, particularly really initiatively, and this is what happens as the recovery plan comes into play, and we need to have particular resources in this area. And nobody seems to look at that and say, and indeed, you know, it strikes me that the recovery plan itself must require a lot of more additional resources than we've got at the moment. Not simply filling in the vacancies we got, a lot more additional resources, because I did read, I think a long time ago, that the £7.2 million operations, etc., that are now outstanding is about a year's output of the National Health Service. So it strikes me that you almost need a complete National Health Service for a year to get rid of the waiting list, and that's not practical. But nobody's actually said, well, we need 10% more resources, and that's going to take us 10 years to do to get rid of the backlog, and that's not what's being talked about either. So it strikes me that a significant amount of resources are required to actually deal with the recovery plans that have been put forward, if they are being put forward in a meaningful way. And it doesn't seem, and we've made this comment before, that there isn't anybody that looks at the system as a whole and says, this is what we need, and this is how we need to go about it. And indeed, going into the international market, in my view, as I said before, is almost immoral. I think taking recruitment from nations that need those resources to deal with the health situation in those countries. And we really ought to be looking at, and indeed we ought to find ways and means of ensuring that our own staff don't go off to Australia and New Zealand and more attractive areas as well, perhaps after they've had all the training and all the investment that's been made in them. But I don't see anybody that's taking on that task in terms of looking at everything as a whole. We see, we see the local people trying to do it, but it strikes me that that's then just working within the pool of resources that exist at the moment, and then you take some resources from somewhere and they take resources from you, and you find it very, very hard then to actually get the resources that you want to actually deliver these recovery plans.
Okay, thank you. If you can try and pull something out of that. If we can try and work more on a question, I think sometimes it's easier for our presenters to try and pull away from it, but I'm sure they can try and work on what you've said there.
Thank you, Councillor. Yes, I think there are some really, really key points raised there, actually, and I identify that frustration. It's not put across as a frustration, but I can understand. I think from how do we know our numbers? Nationally, there is a work underway with with NHSE colleagues. You'll be aware, because it's in the public domain, that there is a huge restructure happening in NHS England, Health Education England, and so resource that we would see at a regional and national level is becoming scarcer. However, as Salmia mentioned previously, we have to, as a county, make our own pathway regarding our data. Should we? No, I have no view whether we should or not, but anyway, we are in Lincolnshire. Samia mentioned we're the first integrated care system to partner with a big provider, with KPMG, and we've had this fully funded from outside of the NHS money, and at considerable cost, because exactly that point, we need to understand our numbers. We know we have a net increase in staff across our providers. We know we have a net increase in staff across primary care. We know we have a challenged situation in adult social care, which remains a very challenged situation. So we know there is huge transient population across Lincolnshire moving out of trusts into primary care, out of primary care into trusts, out of adult social care into the NHS, which is really challenging for our adult social care colleagues. So we have to tackle this as a pool of resource. So the first thing we've had to do, and we started it this year and we're continuing, it's a 3-year programme with KPMG to ensure we have complete oversight of our workforce. So that's a must. We have to know where our staff are. We need to know across all of those localities and locations, whether that's geographic locations, whether that's in critical clinical areas, what, let's say, for example, the age profile of those workforce, because as we know, in the NHS, there is an opportunity to if you have the right pension, to retire and return, or retire and finish at 55 potentially. So we know we have 24 point something % of our workforce in Lincolnshire are over 55 now. So we know that. And that is older than many of our, particularly our Midlands counterparts. So we know. So I'm absolutely endorsing your point that we have to have a grasp of our own data. And we are literally weeks away from having the first cut of that data. We have, Sammy mentioned that that's working across the 3 main providers, the NHS providers. However, 5 primary care networks have signed up in this pilot. So we have 5 primary care networks who are looking at this thinking, well, maybe there's something in it for us to understand our workforce and how we can see it as one workforce. You'll see our backdrops. I don't think I need to do product placement, but one workforce is absolutely our mantra. So how do we avoid poaching staff? We can't avoid poaching staff. And I use that word purposely because that's the word that's sometimes used. So what we have to do is identify, we will see people rotate. If I started a career now as a nurse, I might want to work in different environments. So how do we lessen that issue and actually employ rotational post holders? How do we encourage something we call portfolio roles? So particularly for medics and allied health professionals, so physios, OTs, who want to work across multiple clinical settings in their career, how do we enable that? And how do we engage even with adult social care at, I don't know, a community nurse, so for example, at 55 years old, doesn't really want to still be travelling around the county with patients. However, would be great as a registered manager in a care home, because actually their understanding of working with older people is second to none from a clinical perspective. So we're having all of these conversations. So we cannot wait. Bluntly, I can't wait for the national to catch up with how do we understand this as a wider picture. That's no criticism. We know how challenging it is in one organisation, let alone across an ICS footprint. What I can say, however, so we don't work in splendid isolation in Lincolnshire. So as the SRO for people in Lincolnshire, I work with my counterparts across the Midlands footprint, particularly, so 10 other ICSs. And we share ideas, we share our own understanding of our workforce and some of the challenges and some of the opportunities, and we work from a mentoring perspective around that and buddying, but we're not where we need to be. So it's a really good set of points. The internet, I'll just pick up on the international recruitment. Sorry, colleagues, I don't know if you want to come in, but I'll just pick this one up and then we'll pass back. Thank you to the chair. But from an international point of view, I'll give one example. and we had a recent visit to Kerala in India, and this is not an area where we are taking from their current workforce. They train 60 to 70% surplus clinical staff purely to partner with countries overseas in order for those people to have an experience of working overseas. Now, whether that's a lifetime choice or whether that's about experience. So it's important that we have an ethical and sustainable international recruitment programme and policy. And I can assure members that that is something we do have. We are looking at as one of those areas, international recruitment, where we need to be working more collaboratively together, but we are really starting to see that. But really great point about international recruitment, but I can provide some assurance that we do that ethically and sustainably.
Thank you, Chairman. Thank you very much for the response. I think recognising the issue is part of it. I accept that in the absence of anything that operates nationally, we've got little choice but to operate on a Lincolnshire sort of basis. But your final point, I think it was about India overproducing resources so that they can actually send them into the wide world marketplace is interesting. Perhaps we ought to do the same. And perhaps the people that have been overproduced in India, have got lots of places to go in the underdeveloped part of the world rather than the UK.
Absolutely, great point. Thank you.
Thank you. Councillor White.
Thank you. I'm interested in retention. Do you do exit interviews? And if so, have you learnt anything from that? Are you doing surveys of existing staff to see what would encourage them to stay or what factors are making them think of leaving? And finally, one of the reasons why certain people were retiring, highly paid people were retiring, was the pension thing. And now there's rumours that today they're going to extend the pension allowance for high earners. So that's one factor. But I was wondering whether you ever write to people who've recently retired to see if they might reconsider and come back to the workforce. This happened with the education, with teachers at one stage. Everybody who'd recently retired got a letter, I think it was from David Blunkett. Thank you.
Thank you. I will ask my colleague Sammy, I think, to pick up the retention. I have seen well, very, very briefly, obviously we're doing lots of preparation for this call, but I have seen there's something about the lifetime allowance for pension, so I can't possibly comment on that at the moment. But yes, it is a really key point that we need in order to retain people within the NHS, is that we allow pensions to be flexible. But I'll bring Sammy in on the retention question. Thank you.
Thank you, Kerry. So I've jotted down a couple of pointers in that question. So the first one was about exit interviews. Yes, we do conduct exit interviews, and actually it happens in multiple ways. There's the possibility of having a verbal face-to-face or virtual conversation with someone. But there's also an exit interview survey that's automatically triggered to someone when they resign. So we capture the data on the system, and then there's somebody at the system level that actually analyzes the data to take a look at why people are leaving. We are constantly working on improving the percentage because we have found that it goes in waves. At points in time, there are people who want to have those conversations, want to fill out those surveys, and then there are points in time when we don't have a really high percentage of people who do that. So that is, yes, it is absolutely something we focus on. But rightly, like you said, the second point that you stated was stay conversations. So it's not just about talking to people or finding out data from people who have already resigned, but it's about trying to have or normalize those conversations during the rest of the year about why you stay. Yes, we want to understand why you leave, but we also want to understand from people why they stay. Now, based on the exit interviews and the stay conversations that we've done over the past year, we're currently running a pilot, and we have an individual who's just, we've brought her in as a retention a coach. And all she's doing is we've picked out some pilot groups based on what the data is showing us, and she's just having conversations with people across the various individual provider organizations, just trying to understand from them better why they stay, if they're thinking of leaving, what we as the NHS can do to retain them, ideally within their own organisation, but if not, within other partner organisations, but still within the health and care system. So that's ongoing. The third aspect you spoke about was pensions. Now, the pensions issue is not something that is only relevant for us in Lincolnshire. So it is an area that the national team, NHS England, has taken the lead on. There are multiple discussions that are ongoing, and in April, they've said that we will see some changes to the way the pension scheme works. So you spoke about one point, which is increasing the allowance limit, but they're also talking about other more practical impact on pensions. So currently, if someone chooses to draw down pensions, then there needs to be a break in employment, there needs to be a certain, they can only come back part-time, etc. And those are some of the things that the national team are looking to impact, so that then it's a change that will be applicable for anyone who works on the Agenda for Change contract within the NHS. And we're waiting to hear what those changes will be as well. It's imminent. And the last thing you spoke about was the retirees and whether we're making any attempt to contact them. So we do organize what we call kind of pre-retirement workshops. And I think the example you gave of sending the letter out, we don't do that. Maybe something for us to consider doing. But what we do when we have these pre-retirement workshops is we talk to people a little bit about financial well-being and, with what they can potentially do with their pension lump sum, etc. But we also talk to them about things like lifestyle changes, fitness, etc. Because this is someone who's now essentially going to have a lot more hours on their hand compared to someone else who's working full time. So we talk to them about that, the psychological, emotional impact of being retired, etc. And we ask them to put down their names and their contact details on a piece of paper that we finally collate if they want to be contacted in the future. We do have a high percentage of people who come back, so retire and return essentially. And that's something that we track quite closely as well, just to make sure that we are kind of looking at all those people who essentially want to come back. And again, when they come back, we accommodate the changes that they want to make in their work contracts. So most of them want to come back on flexible work contracts, want to work fewer hours, want to work different shifts. And as far as possible, we try and accommodate that. So I hope I've answered the question posed.
Yes, thank you very much. That was a very comprehensive answer. Thank you.
Thank you. I've got Councillor Smith next, please.
Thank you, Chairman. And Councillor Allen very, very briefly touched on this, but I'm going to go into a bit more detail about possibly retention and possibly losing members of staff. I saw an article a couple of weeks ago, Chairman. Australia are hugely struggling in their rural areas to recruit general practitioners. So much so that in this one instance, a GP, if they'd gone over there, could earn £436,000 and was given a house for free to live in. Now, there's no way our National Health Service can provide such sums of money, but how are we trying to, as much as we feasibly can, sort of keep staff that we've invested time and money in to train to not go to sunnier, warmer climes with a, shall I say, rather tempting offer like that?
Great question, Councillor Smith. So, Wendy, particularly, there's a question particularly obviously around our general practice colleagues there.
Absolutely, more than happy to answer that. I saw the same article and I thought to myself, well, it's not just us that's struggling to get our GPs. We are doing a lot of work in looking at how we attract people, how we recruit them, how we retain them, and the retention is the really important thing. We do train, our vocational training scheme has for GPs in both Boston and Lincoln. We do have big numbers going through that training, and actually in Lincoln we retain about 60% of those in county with jobs, so that's a really good percentage. But we do know again that we do get people from overseas coming over to do our training, and then with the potential that they want to leave again. I think for me it's about understanding the whole aspect of why they're a GP, where they want to work. There's a real
Thank you for that very detailed answer. You mentioned a very key point, which has changed from when I was a small boy, from what I knew and had heard from other people who were GPs at the time. At that time, most wanted to be partners. Now they wish to be salaried. What can be done to try and make that a more viable option so we can retain people? And I appreciate the time we're in, so you may not be able to answer that question, but I thought I'd ask and try.
Yeah, no, that's a fair point. And like I say, through discussions with them and really having that one-to-one review periods, you know, consistently, it's about, well, what is it you want to do? You know, how do you see your working life working? And we want to be able to provide that flexibility in terms of working patterns, like I say, the portfolio careers. And we do have PCM business managers now. We do have practice managers, you know, so we can accommodate salaried doctors. We can accommodate, you know, an increase in salaried doctors, but it's getting that balance right. And in Lincolnshire, we have got more GPs than we had in 2019, so that's great. Compare us to some of our benchmarking in the East Midlands, we have less, but we do have more advanced nurse practitioners, and we do have more direct patient carers in those roles I sort of alluded to earlier. So is that right? Is that wrong? You know, I think people that have gone to their own GP will have seen an advanced nurse practitioner and been very happy with the service. It's just a different way of delivering the service. And it's much more about looking at skill sets, much more about choice of roles, and actually overlaying that with what's the supply and demand like, because that's the real issue. So if we can't get that person, could we get something else? Because, you know, we're dealing with really long lead times in training, etc. here.
Thank you. I've got Councillor Woodliff.
Thank you, Chairman. Good morning. Very interesting so far. I was looking at page 69 of the report, and I take the point about GPs, but the real issue is, of course, care workers down the bottom of the system who are very poorly paid, and as we know that. And picking out the report here, it says that There is an existing and growing demand for workforce and skills levels that cannot be met by the current working age population, probably in Lincolnshire. Well, that's because, of course, a lot of people retire to Lincolnshire. They sell their house in Watford for $750,000 and move up and buy a palace in Boston for 150,000 or whatever. And expect the same standard of service that they would get in Watford as they do in Boston, because that's not feasible, because there aren't the people in Boston, the young people anyway, certainly, to provide the service. So we have a problem with people moving into the county, I think, that kind of upsets the balance of the place. The other thing is, of course, talks about data in January 2022 suggests that caring occupations continue to be one of the toughest roles to fill. Not surprising, the pay is poor. It goes on to say that talks about, the employers can't find care workers who are prepared to drive. That's probably because they won't pay them. They only pay that short time when they're actually with the patient, and then the driving, well, that's your problem. So I think the real issue we have here is, one, increasing the pay and making caring workers that profession attractive to people. Maybe just to resolve something about driving, providing a taxi service for free for these people. After all, why should the driving aspect be so insignificant? Really, it's the caring side that's the important bit, and the state or the county or the NHS should provide the transport for people to get from A to B. Because in Lincolnshire, you can't get anywhere without a car, can you? Wait for a train, you wait forever. Wait for a bus, never comes. From experience. So the issue of driving, do not think the issue of driving as an issue should be taken right out of it. So that the caring side is where the money goes. Pay the carers better, much better, yeah? And take the driving aspect, the transport side of it, so that they are provided with transport to go from somebody in, Curtin to somewhere in Butterwick or whatever, without having to use their own personal transport. Any comments on that?
Thank you. Great set of questions in there. Really challenging and absolutely right on many counts there, Councillor. So particularly around the challenges within adult social care. So my personal experience, I've spent 15 years in adult social care before I came into the NHS 5 years ago. So I absolutely have lived experience and working in HR, so trying to recruit to a lower paid role. We know, and having spent a long time in adult social care, I know, and having actually done some support work in that role just to get some experience of it, the reward comes from the intrinsic satisfaction of working with people. It doesn't. I mean, thankfully, because I won't comment on the pay. That's a decision for policymakers regarding payment into the sector. I can only talk from a workforce perspective. But there is an ongoing challenge. So whatever we experience in the NHS, or even within primary care, which are not agenda for change necessarily, although they're paid more favourably on the whole than probably our colleagues in adult social care. So we have to avoid almost a 2 or 3 tier workforce in health and social care. And so the work we're doing to enable or support our adult social care colleagues is really, really important. We know from patient experience, from a discharge point of view, out of a ward to go home, and to ensure we're able to discharge in a timely way, we need to make sure we have a resilient adult social care workforce as well on that care pathway. So the work we're doing, so one of the attachments that I don't think we've referenced yet is the integrated care partnership strategy. So there are 2 elements to the workforce enablers within that strategy. One is to inspire young people to stay and work in the area. And we've talked this morning already about that, but we've certainly talked about that last time. And the second part of the enabling for workforce was to train and support people who are already working or seeking jobs to gain skills needed to take up jobs. And I will add to that sentence, in health and social care. So we need to ensure that we have youngsters that are growing up through our schooling across the county who are attracted into careers in health and social care. Now, it might be that they, at the moment, go to university, do their nursing qualification and come in at that level straight into the NHS. But we know that many families are unable to access higher education from a financial perspective. So we're really working hard at enabling youngsters at, and we know, I have teenage children, we know you have to target them at 11 or 12 years old. 16, they know everything by that point. So it's really at that 12, 13 years old, why would they want to come into health and care? And it might be, and this is just one cohort, that actually longer term they want to be a nurse because actually that's what they've always wanted to do. They want to be a doctor, they want to be a physio, they want to be, because they've seen something at school or they've seen something on TV that really has attracted them, or they've had caring responsibilities for an older relative. So they really want to do that, but actually the barriers to them are too much. So we're looking from a widening access point of view to enable those youngsters at that 16 plus from a further education point of view, to access that route into health and social care. Now, it might be, and this is where we're working with adult social care, so I'm working quite closely with the chair of Lincolnshire Care Association to ensure that, and I met with the Federation of Lincolnshire Colleges last week in the Care College, which is their shop window into those accessing at 16 years of age, accessing health and social care. They have a policing college, health and social care college, and the like. So how do we as employers, it's incumbent on us as NHS employers to support that, to ensure that our shop window for youngsters coming out of school, out of FE college, to access health and social care careers, because it's an attractive proposition. It might not be financially it might not be the most lucrative career for the first few years, but actually if their final destination is medicine or it's nursing, then actually they do start to hit those higher levels, but their route through is adult social care. So we're working with adult social care colleagues. I think it's a colleague of ours in Lincolnshire County Council who said everybody in health needs an apprenticeship in social care, and much as that, that in itself, it sounds, how would you even tackle that? But I think there's some element of truth in that, so we have to work in a much more joined up manner. So if we know, for example, and we do know that not a lot, but a number of those in adult social care today will work in health tomorrow, maybe for financial reasons, maybe for career progression, we need to ensure the pipeline of those coming behind them is resilient and sustainable. So it is incumbent on the wider health economy in the absence of better pay, better conditions, better transport, road infrastructure, which is outside of our gift. Certainly our gift on this call today, but how do we really support them? So I'm going around the houses slightly, but I think it's really important to stress that we're at the early stages, also working with voluntary sector colleagues. I was talking to the chair of the vet the other day, and again, what can we learn from volunteering? So people who are working in, a supermarket, I won't mention which, want a supermarket today, who actually would be fantastic working in a care home, would be fantastic in domiciliary care. How do we enable, how do we educate people, how do we promote careers in adult social care, and then promote that development of their aspirations, appreciating there are some real financial challenges. And just very briefly, I'll pass over to Soumya. Conscious I've talked a lot there, but just around the cost of living, there's some work happening with adult social care around cost of living. So Soumya.
Thank you, Kerry. So one of the things that came up around November, December last year was the cost of living issues that our members of staff were facing. And this was true not just for the NHS, but very much so for social care as well, very much for the reasons that you highlighted. So we had a team of kind of project officers who sat down, worked on coming up with a list of discounts And this meant conversations with multiple organizations. And these discounts, we made sure were applicable not just for the NHS, but for social care as well. And it was very, very well received by our colleagues in social care, because the feedback to us was, for the first time, our members of staff feel that it's just as privileged to work in social care as it is in the NHS. So without really having the member of staff tag that an NHS employee gets, what are the discounts that social care can avail themselves to? And we ran it kind of as a discounts over the 12 days of Christmas, and every day we launched a new discount. We created social media campaigns, emails went out, leaflets went out, etc., to members of staff, and this was very, very well received. And absolutely applicable to members working in the NHS as well as social care. Thank you.
I'm going to cut it off there, Councillor Woodliff, because strictly speaking, we've wandered off into Adults Committee and we're the NHS-funded services. So I've allowed it because I think that it's pieced in quite nicely together, but I do think that it's more a part for the Adults Committee and not us to be going into the social element side. So I think we've had a good sort of discussion there, and I think I'd thank the speakers for what they've covered, but for the NHS, as I say, that's what we're here for, not for adult social care. But thank you. I've got Councillor Cleaver next.
Thank you, Chairman. Thank you, the three speakers, for the report that you put in. I must say it's heartening to witness the thoroughness and the enthusiasm that comes out both in the reports and also in the answers that you've given so far during this session. And it's also great to see joined up across primary, secondary and adult social care. I just have 4 points, if I may, just very quickly put to you on my reading of the report. First of all, I noticed I saw no mention of the availability of childcare provision for working parents as a recruitment and retention incentive, and I welcome your thoughts and views on that. On the question of, that's the first point. Second point, on the question of international recruitment. Whilst, of course, there's an understandable reluctance to engage with the private sector recruitment providers in the domestic labour market, all of the major companies in the recruitment sector in the UK are major multinationals and have considerable experience of international recruitment. As a result, they all operate in all European countries and beyond. And I wonder whether it is viable or appropriate to seek their expertise in how we conduct international recruitment. My third point, relating to primary care, I think those of us who have come across primary care providers which have been rated as less than good by the CQC are thoroughly aware of the difficulties they have in recruiting staff due to the stigma of their less than good ratings. I wonder what you are able to do to assist those, because clearly that is one of the major pinch points in the primary care system. We obviously don't want those providers we want those providers to be able to recruit the staff they need to get their ratings back to good and beyond. And I think that's quite a major issue for us. Also on primary care, is there not an issue for the non-GP staff in primary care, who are most numerous and are, again, important and key members of staff, both the direct care staff and the administrative staff? The fact there's not a level playing field, is there? Because they're not on NHS terms and conditions. So is there an issue that a lot of the recruitment problems that GPs are experiencing could actually be overcome by their staff being on the same pay and conditions, holiday entitlement, sick pay entitlement, pension, of course, as their NHS employed colleagues? And finally, my fourth point, in the people plan, under the rubric of new ways of working and delivering care, there's the use of the word reservists, which intrigued me. The word only appears, there's only one reference to it, and it's there. Could you explain what reservists are, please? Thank you.
Thank you, Councillor Cleaver. So I will ask my learned colleagues, I think. So Sami, if you could pick up the, I mean, the childcare provision is employment specific. So there isn't, we don't have the detail to hand today. It is part of the offer to employees, but it is not something at this moment from a system point of view that we're looking at across the piece, but certainly something we'll take away. Thank you for raising that. So I'll just, from an international recruitment, Salmia, just to pick up with yourself maybe, and also the reservists, if that's okay. And then Wendy, if you could pick up the 2 primary care ones. Thank you very much.
Thank you, Kerry. So yes, Councillor, I'll start with the international recruitment. So we have actually worked with multiple big companies, kind of learning from them on what's worked well, kind of processes. And I think, you know, this is something I say, pinch with pride. So other people have trialed, experienced, failed. There is absolutely no need to go through the same journey ourselves when other people have done it differently and learned from their journey. So we are constantly in touch with various companies, private as well as other NHS trusts that have done it differently. And while the current focus is India, across the county and across the region, actually, there have been other international recruitment areas of focus. So whether it's the Philippines, whether it is Spain, whether it's Italy, in terms of specific roles, or specific staff groups that we've looked at. So that's definitely something that we continue to keep in touch with. And from a national NHS England perspective, they have a whole team dedicated to doing just that, to look at best practices. And they share a lot of that best practice with us so that we don't have to kind of make those mistakes and learn from them ourselves. So that's on international recruitment. On the people plan and the new ways of working, so reservists, yes, that's one of the things that we've pinched with pride from the armed forces. It's not the same, so it doesn't necessarily refer to armed forces recruitment within the NHS, but it's along the same principles. So we look at people that can sign up for a minimum working and that we can call upon when we feel the need. So usually, or last year, we used it for tackling the winter pressures, where we know that we have an increased footprint within, for example, the hospital, the acute hospitals. So that's the only similarity. It's not actually recruiting armed forces into the NHS.
Okay, so I'll pick up on the primary care questions if I can now, Councillor. So the 2 things that you've raised are literally 2 risks on our primary care people group risk register. The first one regarding the CQC ratings, I'm working with ICB colleagues and the local medical committee as well, looking at, we mentioned before about data sets, knowing who we've got, who we need based on population health management, our clinical strategies, where the gaps are. So that's basically our shopping list for which staff we need. Within that, we're also overlaying that with some softer business intelligence. CQC quality mark is one of those real, challenges that we're working with. And it's almost about putting those 2 things together, the data sets and the softer intelligence, and then asking the question about overall resilience of that practice and overall sustainability of the workforce in that practice, because that is really, really important. So that's one thing that's definitely in the plan, and it is on the risk register because it is a real issue. The second one, definitely, I've seen staff move either way. So I've seen staff come out of secondary care because they don't want to work weekends or bank holidays. I've seen staff go back into secondary care because they want better maternity leave. It is something that happens. Is there an appetite for harmonisation? I don't know. This is one of the things that we're looking at the moment. Like I say, it's very, very challenging because we've got a big diversity of businesses as well in primary care. You might have a partnership, they're quite small organisation. You might have a big federation and everything in between. So it's something that we are seeing, particularly with some admin staff as well in primary care. So it's not just the clinical staff that we're seeing it, because I think we've had the Aldi effect, where you can go to Aldi and earn £10.50 an hour, and you can work in a busy reception with day-to-day challenges. So it's something that, like I say, I haven't got the answers for today, unfortunately, but it is something that's on our radar and something that's on our risk register. And I will be speaking to the PCM business managers, because they raised it in a recent time out, and we're hearing it in several quarters now. So it's something that we just need to probably do a little bit of work on and say, what is it that we could do with this to make things easier for our staff?
Thank you for your answers. I found that quite reassuring. Thank you.
Thank you. I don't have any further speakers. I've got one question, and I just wanted to say how robust and thorough it has been on this presentation from you. In fact, I had about 4 questions, and you've answered them as you've gone along, so thank you for that. My one question I've got left is, if tomorrow you could fill 100 of the 500 nursing vacancies and 20 of the 100 medical vacancies, in which service areas would you wish to see the post filled? For example, would it be paediatric nurses or A&E doctors, or perhaps posts in primary care?
I will answer that with, we would immediately talk to our clinical colleagues. So Claire Raybould, who has just been on the call, we are, and that's not ducking the question, that's a really, really great question. I, at this moment in time, have a certain lens as a director of people, but certainly I would defer to my clinical colleagues. Where would we need, where are those areas that are the most fragile today or tomorrow, when we've got these 100 new people, and we would support them in enabling those services with those new recruits. That I appreciate that's not answering your question, but I would certainly, Claire Raybould would be my go-to person, and I'm seeing her tomorrow, so if indeed we do, I would absolutely, not being flippant, but genuinely, I would have that conversation with our clinical counterparts, because I'm sure they would absolutely have a consensus, because we know where the pressure points are currently within these services.
Okay, thank you. In which case, once again, I'd just like to thank our presenters for this morning's excellent and robust presentation. And I'm going to propose that we support the progress with the Lincolnshire People's Strategy and to look forward to further progress over the coming year, and have an update in 1 year's time. Do I have a seconder for my proposal? Thank you, Councillor Smith. All those in favour, please show. Thank you. That's supported. Any against? Any abstentions? Thank you, Councillor Woodliff. Okay, in which case that's carried. Thank you very much. And we'll move on to agenda item 7, the quality accounts. This item was circulated as part of the agenda pack on pages 77 to 84, and I'll hand it over to Simon.
Thank you. Excuse me. Thank you, Chairman. For long-standing members of the committee, Chairman, long-standing members of the committee will recall that this paper is run past the committee each March. A quality account is a document that certain NHS or providers of NHS funded care are required to prepare. This excludes GP practices, but it includes certain providers who have above a certain threshold in terms of numbers of inpatients. The document they prepare each year can be anything from about 70 perhaps to 100 pages, and it is a focus on quality, not on finance, and there is an obligation on the provider to circulate the draft document to health scrutiny committees, local health scrutiny committees, for comments. So this has previously been done in Lincolnshire by means of a working group, but there may be other ways of doing it. The first question for the committee is, I suppose, looking at the list on page 80 of the local, if you like, the local providers, which providers, if any, the committee would wish to make a statement on. And then the second question for the committee is how you would wish to do it, perhaps through a working group or possibly even over email, if that would be preferable, or possibly even a combination of the two. But that is the item. I would say, just on the table, the CQC ratings have been, some of them, as I think I say in the report, are quite dated, and I think a lot of this is as a result of the pandemic and some of the CQC stepping back from inspections. And I think the CQC recently has been holding back, even over this winter period, from certain inspections. But I'm quite happy to take questions, and happy to take questions and any suggestions on how this is managed this particular year. Thank you.
Thank you, Simon. Just before I bring in, I've got 3 speakers listed so far. In our meetings that we have across the Health Wellbeing Board and so on, perhaps it's a question that we can be raising with them when they would expect to be re-inspecting these, because I think, as you say, when you're going back as far as 2018, it would be nice to get an inkling, because it may well be that an inspection happens tomorrow and one of these areas we're not necessarily looking at turns out to be having moved from, let's say, good to requires improvement, or perhaps requires improvement to good. You just don't know at this point, and I think that's the difficulty. So, Councillor Harrison first.
Thank you, Chairman. I'd be particularly interested in the NLAG one. It was inspected 2022 anyway, but its priorities are so different from all the others. Being a user of Grimsby on occasion, and I know a lot of East Lindsey residents use it, I think we should perhaps dig a little further with this one.
Thank you, Councillor Harrison. As you'll be aware, at the moment in time, they are creating yet another scrutiny group, which Councillor Smith, myself and Councillor Bunny are all sitting upon. So I think it could well be pertinent at this point to be maybe looking at it. We haven't previously, because of course they have got other health scrutiny committees, you know, whereas we do tend to concentrate purely on the Lincolnshire offer. I've got Councillor Allen next, please.
Thank you, Chairman. I'd just like to make a comment on the CQC rating issue. It does seem as though we ought to be putting pressure, as you indicated you might be able to do so, to see if we can get them back working after having the COVID holiday break. Because it does seem as though some of these are very old and some of them do need reviewing, and the concern that I have is that as we come through this difficult period and go into a different difficult period, shall we say, in terms of the recovery plans, that the ratings may well suffer as a consequence of that, and it may well be one of the reasons why the CQC has not been going around the hospitals at the moment, because they don't want to actually carry out the inspections because they may be very afraid of the results that may be coming out of it. But it does seem as though the more recent ones tend to be quite poor, and some of the better ones seem to be quite dated. In terms of the paper itself, I can't recall seeing this item before, Chairman, in terms of a report, and I've been in place 2 years now, so I was surprised about that.
It's every year, and then we always have a working group, and it's always reported back to committee for each individual one. It's been, every year without fail for at least the 6 I've been on it, if not more. So it.
My apologies then, I must have missed it. If that's
there's a working group, and if you want to volunteer for it, we're always normally there's a working group, should I say, and we're normally very accepting. I think Councillor White sits on most of them with others, so and Ray and Linda as well. So it's often incredibly interesting, I may say. Right. But and in terms of the CQC, I will jump to their defence. To be fair, I think they followed what guidance they've been told, what meetings we've had with them. They're very, very keen to ensure that inspections take place. They work incredibly closely with Health Watch as well, and make sure that those sort of entry and view times happen. So I think they're very, very keen on it. But nationally, they've been told stand backish.
That you've had some sight of in terms of why perhaps the inspections aren't taking place? I know certainly during COVID they didn't want to go into the hospitals, but is that the case now?
Not so much guidance. I think we're more of what we've been told is that they did more virtual appointments over the COVID period. Interim view, I think that there's been some training that's happened for Health Watch now, and they've been going in and looking into it. I think it's a lot of catch up at the moment in time, and they also understand that the hospitals are under pressure. I don't know if you want to add anything further, Simon.
Well, thank you, Chairman. I've noted down the comments on the CQC inspections, and I'll get. I will raise this and get some more information on what their planned inspections are, perhaps in the coming year, and what the current arrangements are. Thank you, Chairman.
Thank you. I've got Councillor White.
Yes, I'd just like to say that I looked at this and I thought it was still, although we looked at United Lincolnshire Hospital NHS Trust last year, I think it would still be interesting to see how their priorities have worked out, because they obviously need to make progress. And then the second one I thought was the Lincolnshire Community Health Services NHS Trust, which we didn't look at last year. I'm not sure when we last looked at it, but those would be my suggestions.
Thank you. I think we've always took the view, as I say, they are incredibly outdated, but we've always took the view that if they're outstanding or good, we've concentrated on those that are obviously coming up as requires an improvement, or, you know, in the case of United Lincolnshire Hospital Trust, you know, that's our main trust in Lincolnshire, and that's the view we've took with that, but that's noted, and of course at the end we'll go around and make a decision. Councillor Cleaver next.
Yes, I also think it would be very useful to consider the Lincolnshire Community Health Services NHS Trust, particularly in the light of the fact they run all our UTCs, so which is a big issue for many of us at the moment. So yeah, I'd like to include that one, please.
Okay, thank you. I've got Councillor Loughagan.
Thank you, Chair. Yes, the two I was looking at is the ULHT, even though it's been done fairly recently. It's obviously the one that's going to impact on most of the people we represent. Or the other one is EMAS.
Thank you. Haven't got any other speakers at the moment in time. I think we've done EMAS every year for the last 6, I think now, something like that. ULH as well. So entirely up to the committee. What I've heard so far is that we'd quite like EMAS, Lincolnshire Community Health Services, NLAG and ULHT. Is that correct? Is everyone happy with that? Thank you. In which case, how would we like to do it? We'd like to do it via email or in the old format, which is the working group, which then reports back and it's signed off then in total by the committee. Councillor Harrison. Could you just put the speaker on? Because on the live, they can't hear you outside.
Yeah, sorry. From my own point of view, you know, with the district elections not too far ahead, you know, do you have a date when you're thinking you could fit it in, please?
Simon?
The some providers are very quick off the mark and will get theirs. And one of the ones you've not mentioned today, like LPFT, will usually have theirs ready very soon after the end of the year. Probably in the next 2 or 3 weeks, I'll be hearing from somebody. Some of the other providers take a little bit longer, and because the deadline is the 30th of June, I think in previous years we have had occasions where we've had a working group very late in May for, or even in early June, considering a draft statement, because the providers themselves, they have a window, and some of them are perhaps use the full window to actually prepare their documentation. I'm sorry, that's not really a helpful answer, but it's just we are dependent on them. So we might be, I will get the information when they think they're going to be ready. I will then try to stand up a working group, and hopefully everything will come together and we'll be able to get the document out about a week or so in advance to give the members of the working group an opportunity to read it. Thank you, Chairman.
Yeah, I think that one of the difficulties we have got on this occasion, and as Councillor Linda Whitton's just said, you know, with Purda being there as well, it's going to prove difficult, and there will be members within this committee that will be standing for election, and obviously there might be members that may not be here after May, so it's quite difficult. So I think realistically it would be good to get a reasonable amount of volunteers to come forward to sit on the working group, and then we can sort of bottom it out in that way, because I think that realistically that's the best way forward, because with the best of the will in the world, not everyone responds to an email. So that would be my recommendations, and I would look at covering those four, which is EMAS, LCHS, NLAG and ULHT, and I would like a pool of volunteers if possible for that. I'll put myself forward because I enjoy it that much. Councillor Linda Wootton, Councillor Ray Wootton, Councillor Allen, Councillor Cleaver, Councillor Loughagan and Councillor Harrison. Did you go? Yes. Thank you.
I would volunteer, but I'm not standing, so therefore it would be a waste of time, wouldn't it?
Okay. Okay, thank you, Councillor White. Okay, I think that we've got a clear way forward there. So all in favour, please show. Thank you. Those against? And abstentions? Councillor Woodliff, thank you. Okay, that's carried, in which case we'll now move on to agenda item 8, the work programme. Simon.
Thank you, Chairman. If I could just ask the committee to focus on page 86 of the papers. We have 3 items listed for the meeting in April. One of those items is the report of the Reducing Suicide and Mental Health Working Group, which we had intended to bring to this committee. There were some loose ends that weren't necessarily, some of the loose ends came from the feedback, but some of them were from, if you like, outside statements from government, which seem to coincide with the drafting of the report. So they just need to be tied up with the report for the next agenda. From May onwards, I'm just going to say it's going to get busy. I'll leave it there. Thank you, Chairman.
Yeah, thank you, Simon. I think April, as you'll see, is more inward looking because NHS colleagues really don't want to be in attendance at the height of Burda. So that's why it's more what's provided sort of within the county council and so on. But as Simon has said, we're getting more and more requests. So from May, it really will be incredibly busy moving forward. So any other comments, please? Councillor Cleaver first.
Thank you. I was intrigued by Appendix A at the very end of the agenda pack. So much so that I actually counted the number of rows there, and it actually comes to 89. And I think it's worth comment that we've done a lot of work, and we should pat ourselves on the back a little bit as a committee for covering 89 subjects in 2 years. I think it's something to be proud of. However, there's only three of them have got a little red square to say that they're concluded, which is also noticeable. And I'm bound to say I noticed one of them is Lakeside Healthcare Stamford, which surprises me slightly, given that they're still rated as requires improvement.
Thank you. Yeah, basically, the red ones, when we remove them from the work programme, anything can go back on the work programme at any point. But what we do is we take a decision on that item, and on that item, if it's voted through, that's as far as we want to go with it, and there's no update for now, that's how it remains. As I say, anything can go back on there at any particular point, but we just felt on those particular items, we are where we are. As you'll know, with any of the same with Hawthorne will be coming up as well in Skegness, we can only come to a certain point. They still do tend to be their own businesses, and it's an ICB thing. We more bring them in as opposed to the individual clinic.
Yeah,
Councillor Cleaver.
I get that, but it's just a bit odd that there's only 3 out of 89 that have got red dots on them.
As I say, it's always done by committee decision, and as I say, can always come back. So, Councillor White.
I'd just like to thank Simon for that report on suicide. I thought it was excellent, and it must have taken a lot of work because we had several meetings and you had to draw it all together. So, thank you.
Thank you, and it will be coming, as I said already, to the committee next month. Thank you.
I think you thought you had it all just about organised, and then a lot more came in. So, thank you, Simon. It's much appreciated. Councillor Harrison.
Done it again, sorry. Are you willing to accept any more suggestions?
Absolutely, that's what we're here for now, and so we will take suggestions, and if the committee is happy to continue, we will.
Well, I think one of the things on the NHS plan way back when was to try and reduce the use of opioids. I'd be interested to find out whether they actually have succeeded in that, because that was really important. And the other one is MSK services. In nearly all the indices of disease that we get, MSK problems are very high up there, and we use various contractors, so I would be interested to see some of the outcomes of that.
Yeah, I think we could, well, we'll have a conversation with colleagues within the NHS, whether or not they feel there's a full item or whether it would be an extensive announcement. We'll have a look and see what we can bring back potentially. So, Councillor Woodliff.
Thank you, Chairman. Was nuclear medicine on that list? I didn't spot it. I unfortunately was unable to come to that one which we had recently because I wasn't able to use my car because of the petrol and the railway line. Well, we know what the railway line's like. Disastrous. So I missed that, unfortunately. It's a really great pity because I really want to attend that. So, nuclear medicine, is that on the list or not?
Simon?
Thank you, Chairman. That is one of the outstanding items because the committee made its response to the consultation and I think we're waiting for confirmation of how they've made a decision in taking that forward. But that's something I'll get information on. Thank you.
Is that acceptable, Chairman?
Yeah, that's absolutely something that we would be looking at anyway. Of course, everything NHS will come to a complete standstill until after the election now, so we won't hear the outcome of any of the consultation or anything else, but it's something that's there. It's not disappeared off, but we're just awaiting a response on it penultimately.
Thank you, and I must apologise for not making that last meeting. It really was annoying. Sitting on a sleeper station waiting for a train which wouldn't come.
These things happen, unfortunately.
They do.
So, absolutely, thank you. Any other comments on the work programme? In which case, I take it we're all happy moving forwards with those suggestions and what's listed. So can I take a vote? All in favour, please? Yeah, that's supported unanimously. Thank you. Okay, in which case, that brings the meeting to an end and look forward to seeing you in April. Thank you all very much.